Hello, let's continue with our session on diagnostic stewardship. In diagnostic stewardship, we focus more towards rational testings for diagnosis of infections and resistance. So our algorithm also focuses more on rapid diagnostic tests and molecular tests. Say for a particular case of pneumonia, when we do a molecular test or nucleic acid amplification test for detection of carbapenems. Now, based on the detection of the antimicrobial resistant genes, say it is MECA in the case of gram-positive cocci, or if it is MBL such as or NDM or IMP or VIM for Enterobacteria or KPC or OXA48. Accordingly, the antibiotics are selected. For example, if it is MECA gene, then we select antibiotics like ceftobiprole or ceftaroline or linezolid or vancomycin. If it is no, then treat according to pathogen identification. If it is MBL, then we select antibiotics like ceftobiprole plus Astrotium or cefiderocol or colistin and others. If it is KPC OXA48, then we select ceftobiprole or meropenem ivermectin or colistin and others. So this is how the basis of the detection of antimicrobial resistant genes, the antibiotics are selected. So this is one of the intervention of the strategy of diagnostic stewardship to utilize more rationally the molecular diagnostic test or rapid diagnostic test for the immediate initiation of an empirical or immediate initiation of the patient treatment. If you see the pre-analytical, analytical, and the post-analytical phases of diagnostic stewardship, the pre-analytical phases, in terms for diagnostic stewardship, we do the risk stratification of patients, or computer physician order entry educational prompts are put up in place. Required indication for the urine culture are mentioned and specified. And proper sample collections are specified. Expedition of the lab transport of the sample is stressed upon. Specimen refrigeration and use of boric acid preservative is advised. But the antibiotic stewardship institutional practice algorithm is put into place. Educational initiatives are used. Antibiotic restrictions policies is put into place in antibiotic stewardship. If you do the analytical phase in diagnostic stewardship, you do the urine analysis with reflex culture, with restrictive criteria for the general ward and ambulatory specimens. Then there is a policy for rejection of the contaminated urine specimens based on cells and epithelial cells found. In antibiotic stewardship, for the analytical phase, we stress upon the future planning regarding implementation of molecular diagnostic modalities for early stewardship intervention. In post-analytical phase, urine culture, the diagnostic stewardship mentions about the electronic prompts to consider asymptomatic bacteria and necessities for treatment and selective antibiotic reporting, while antibiotic stewardship stresses upon antibiotic post-prescription review, institutional guidelines outlining the appropriate duration of treatment, the urinary antibiograms. So that was about the different interventions for diagnostic stewardship and antimicrobial stewardship in pre-analytical, analytical, and post-analytical domains. For example, say to take an example, say example, patient without catheters, then the appropriate would be dysuria, suprapubic pain, flank pain, postural ankle tenderness, or septic shock. Then uncertainty will be fever, systemic leukocytosis with no other known cause, while inappropriate will be altered mental status or change in urine characteristics. While with the patient with urinary catheters, the appropriate will be dysuria, suprapubic pain, flank pain, postural angle tenderness, or septic shock. While uncertainty will be fever, leukocytosis, and no other known cause. While inappropriateness will be the change in the urine characteristics. So that was about the appropriateness in inappropriateness for particular samples for patients with urinary catheters and without urinary catheters. What are the appropriate practices then? For urine culture reports, inform the clinician that even a high colony count may not represent a true infection in the absence of symptoms. Nudge the clinicians to not treat asymptomatic bacteria. Nudge the clinicians to not treat mixed flora. Then help them to differentiate between colonization, contamination, and infection. Withhold the urine culture results when there are more than 2 bacterial strains identified in culture. Preferentially report only IDSA recommended antibiotics if the organism is susceptible. Withhold the fluorocarbon susceptibilities unless there is resistance to oral antibiotics. Inappropriate practices includes nudging the clinician to not treat if there nudge the clinician to not treat if there are less than 1 lakh colony count of bacteria. Withhold the information about urine culture organisms identification and susceptibility unless the clinician contacts the microbiology laboratory. So that was about the appropriate and inappropriate practices. Then there is also significant role of the biomarkers. You can refer to this article, How to Use the Biomarkers of Infection or Sepsis at the Bedside, a guide to clinicians. Rapid identification and sensitivity testing in stewardship plays a key role. Usually, the culture and sensitivity report takes about 30 to 72 hours. But when we make use of rapid identification sensitivity, it is completed in 30 to 40 hours. While rapid AST is done, then it comes to about half to 8 hours. Then also there is a key role of nucleic acid amplification test and molecular test or FISH for culture. Rapid diagnostic implementation into clinical pathways needs to be considered. You can refer to this article or published in clinical infectious diseases. In the initial stage, rapid diagnostic test is essential at this stage. The time frame is within the first 4 to 6 hours. The objective is to determine whether an antimicrobial is required. Example is group procalcitonin rapid diagnostic test. Then patient care pathway on treatment stage. Time frame is that is within the 24 hours. The objective is to facilitate targeting of therapy. Examples include molecular testings. And then the de-escalation or escalation stage. The time frame is 24 hours to or more. The objective is to facilitate early IV to oral switch to facilitate de-escalation of antimicrobials. Examples include de-escalation. Refer to this article, Diagnostic Stewardship Interventions that make a difference. The purpose of diagnostic is to help inform patient care and reduce uncertainty in medicine. However, inappropriate use of diagnostics can lead to unnecessary interventions, increased cost, and potential harmful consequences. Diagnostic stewardship aims to reduce these harms by informing clinical decisions and educating providers. Advancing diagnostic stewardship for healthcare, accident infection, antibiotic resistance, and sepsis. You can refer to this article published in the Clinical Infectious Diseases. The role of the clinical microbials and the identification in patients is important. Examples of such interactions are the roles of clinical microbiology that play in the stewardship program are as follows. Their role of the clinical microbiology includes advice to the clinicians regarding infection management, recommendation for appropriate collection of the samples, selection of the rapid diagnostic tests, timely and accurate results reportings, then improved reporting of results to clinicians to influence the infection management and antibiotic prescription, then surveillance and generation of data that informs treatment guidelines based on local epidemiology, then performance of advanced tests to establish molecular mechanisms underlying the resistance and genotype of pathogens. So clinical microbiologist along with the ID physician plays a key role in the antimicrobial stewardship program. To summarize, utilization of the lab test for diagnosis has a major impact on appropriate diagnosis, hence the right treatment, cost of care and the cost of misdiagnosis, clinical impact of the wrong diagnosis. The clinical faculty in the hospital system needs a structured and supervised approach to utilization of lab tests. That is when, how, what, why. In terms of infectious diseases, the clinical microbiologists are best suited. Diagnostic stewardship programs help us achieve this. That's all in this session. Thanks to all for the kind attention.